All right, let's jump right in. If you're a trainee in any clinical setting, I guarantee you're going to see patients who are struggling with sleep. And it's so much more than just a simple complaint. Chronic insomnia is a really complex medical disorder, and it has a huge impact on a person's health. So in this explainer, we're going to break down a high-yield, super practical approach that you need to diagnose and manage it effectively. So here's our game plan. First, we're going to get a handle on just how big this problem really is. Then we'll build your diagnostic toolkit, focusing on what gets you to the answer fast. After that, we are diving deep into the gold standard therapy. That's cognitive behavioral therapy, before we cover the supporting role of medications. And then we'll wrap it all up with the clinical takeaways you can literally put into practice tomorrow. Let's do it. Okay, first things first, let's really frame this problem the right way. We're moving beyond the idea of someone just having a rough night and into the territory of a really prevalent and impactful medical condition. Get this. According to our source material, a staggering 1 in 10 adults meets the full diagnostic criteria for chronic insomnia. Now just think about that for a second. Think about your own patient panel. That means this condition is walking into your exam room every single day, whether it's the main reason for their visit or not. So how do we actually define it clinically? This isn't just someone feeling tired, right? It requires 3 very specific things. Think of it as the 3-3-3 rule. First, the symptoms have to cause real distress or get in the way of their daily life. Second, it's got to be persistent. We're talking at least 3 nights a week for at least 3 months. And third, you've made sure it's not being caused by some other sleep, medical, or mental disorder. This framework is your absolute foundation for a good diagnosis. Okay, so we've got our definition down. Now let's talk strategy. Once you suspect chronic insomnia, what's your next move? It all comes down to a systematic evaluation. The single most important thing you can do, the thing that gives you the most bang for your buck, is a really thorough history. Forget expensive tests for a minute. You have to ask about everything. Yeah, prescription meds, but also over-the-counter stuff. Their caffeine habit, how much alcohol they drink. You got to dig into their sleep patterns. Is it trouble falling asleep, staying asleep, or both? And what's their bedroom like? Seriously, a simple sleep diary can be an incredibly powerful tool to get the real story. So, is a sleep study needed? This is a question you're going to get, and you might even wonder about it yourself. The short answer? Almost always, no. No way. The source material is super clear on this. Diagnostic testing, like polysomnography, is not a first-line approach for insomnia. You'd only order one if your history is screaming that there might be something else going on, like sleep apnea. All right, this next part is maybe the most important thing we're going to talk about when it comes to management. Let's get into the gold standard treatment, cognitive behavioral therapy for insomnia, or CBTI. And look, this isn't just my opinion or some suggestion. This is a direct quote that reflects the clinical guidelines. Before you even think about reaching for a prescription pad, the evidence points squarely to CBTI. And why is that? Well, because it works. It provides long-lasting benefits with pretty much no risk of side effects, which is something we just can't say about medication. So what actually is CBTI? It's really a therapy with a few different parts. So you've got the cognitive piece, right? That's all about tackling those anxious thoughts about sleep, like, oh no, if I don't get 8 hours, tomorrow's going to be a disaster. Then there's the educational part, where you teach the basics of good sleep hygiene. And finally, the behavioral part gives them actual strategies, like stimulus control, which just means the bed is for sleep and intimacy. That's it. And even sleep restriction, which sounds weird, but it actually works by making their sleep more efficient. And sleep hygiene is stuff you can teach any patient, like today. Simple, actionable advice like having a regular bedtime, cutting out caffeine in the afternoon, and putting down the phone before bed. But here's the crucial clinical pearl from our source. Just teaching sleep hygiene by itself is not effective as a standalone therapy. It's a really important piece of CBTI, for sure, but it's not the whole shebang. Okay, let's talk about medications, and notice how we're framing this. The supporting role. That is absolutely crucial. Pills are not the star of the show here. They are a tool, and one we have to use really carefully, mainly as a supplement to the behavioral strategies we just talked about, not as a replacement. Before you prescribe anything, you have to remember a few things. First, it has to be a shared decision with your patient. You've got to talk through the risks and the benefits. You should also be targeting their specific problem. Is it trouble falling asleep or staying asleep? And this is critical. This is for short-term use. We're talking no more than 4 to 5 weeks, just to help break a bad cycle while those more effective behavioral therapies start to kick in. This table gives you a really nice high-yield overview of your main options. You've got the non-benzo agonists like zolpidem, which work fast, but you got to watch out for next-day grogginess and other weird sleep behaviors. Then there are the orexin antagonists like suvorexant. They work on a totally different pathway, but can also cause some next-day drowsiness. Melatonin agonists like Ramelteon have a pretty modest effect, but they're quite safe. And finally, if you absolutely feel you need a longer-term option, low-dose doxapen is what the source material points to as probably the best choice. Think of this as your final safety check before you prescribe anything. Always start with the lowest effective dose. Try to avoid drugs that are going to stick around too long and make your patient feel hungover the next day. A huge one, always warn them about mixing with alcohol. And please, please, please try to avoid benzodiazepines for insomnia. The addiction risk is just too high. Oh, and also steer clear of over-the-counter antihistamines, especially in your older patients, because those anticholinergic side effects can be really nasty. Okay, let's boil all of this down. What are the absolute bottom line things you need to walk away with and bring right into your clinic? When you put these two side by side, it's really not even a contest, is it? CBTI gives patients durable, long-term benefits because you're teaching them skills they can use for the rest of their lives. Medication, on the other hand, comes with the risk of tolerance and rebound insomnia when you stop it. CBTI has basically no side effects. Meds come with a whole list. But maybe the most important thing is that CBTI empowers the patient, while pills can sometimes create dependency. This is exactly why CBTI is and has to be first line. So I'm going to leave you with a challenge, a practical challenge. Look, you might not be a CBTI therapist, but you can be the one who gets the ball rolling. In your very next clinic visit with the next patient who mentions poor sleep, can you find 2 minutes, just 2 minutes, to start a real conversation about sleep hygiene? About making sure their bed is just for sleep, or about the impact of that late-night screen time? It seems so small, but that simple conversation can be the first step that leads to real, lasting change for your patient. That's your challenge. Go for it.